Do you want to start?
We're just going to ask everyone that as you log in, you mute yourself and turn off your video to improve connectivity. And I think Sam is going to start us off, although are we almost at the number of participants? Michelle, what is the final number that you had? Because we're up to 15, including all of the presenters, though, remember?
So from the list, I have 13.
So the list has 13 people on it, plus us.
Yeah,
That's
the
about
list
right.
I received, yeah.
Okay.
Okay, so shall we begin then?
Okay. Sounds good. Just a reminder to have people mute themselves.
Okay. Okay, great. So microphones aren't working, but that's okay. Such is all the tech issues of all these days. Welcome everybody to the first presentation from the Safe and Understood project. We are very, very excited to have reached this point of the project and to be sharing really exciting findings with all of you who are here with us today. Before we get started, just a quick reminder to please all mute yourselves. And I'd like to start by giving a land acknowledgement and knowing that people who are joining us may be joining us from different areas around the country and different territories. I'll just read for the head offices of the Child Development Institute. We acknowledge that the land on which we work is in the traditional territory of many nations, including the Mississaugas of the New Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, the Wendat, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Our community is home to many diverse First Nations, Inuit, and Métis people, and we recognize the enduring presence of Indigenous people on this land. I'd like to welcome Dr. Angelique Jenney and Dr. Katreena Scott, who have been leading this project over the years. And I'm welcoming them and excited that they're here to share with us the findings from the Safe and Understood project. So go ahead and I'll hand it over to you, Angelique.
Thank you so much, Sam. And thank you, everyone, for attending today. Just another, I think the last person to mute just muted. So this is very exciting for both of us to be here. That Katreena, I'm trying to think back that sometime in 2014, we had this conversation in a coffee shop about what would be the most amazing research project. And then all of a sudden there was this call and it seemed to fit perfectly what we were hoping to do. And then I'm pleased I see Shannon is with us from the Public Health Agency of Canada, and a few phone conversations later and a lengthy proposal. And here we are today, 5 years later, having actually been able to kind of fulfill this dream that started in a coffee shop around how we might be able to intervene with families to promote better outcomes for children and prevent recurrence for young children who are victims of domestic violence. I'm going to start. We have a very packed agenda in terms of the amount of slides. It is a 5-year project, and we are going to just touch on things. There'll be other presentations that we're going to do, for example, for CDI staff around practice implications and things like that. So I'm going to give a quick Safe and Understood project overview. Then we're going to talk about the 2 programs, Mothers in Mind and Caring Dads. We're going to talk about how these programs were implemented over the past several years, the research that we conducted and our findings, our preliminary findings in some cases, and then a quick conclusion. I do have the chat box open, so at any time you can send a message if you are wanting to ask a question, or you can save your question to the end because we have left a Q&A time. Is everyone hearing me okay? So just another thank you to the Public Health Agency of Canada, for without whom we would not be here today. They have not just financially supported us, but absolutely emotionally and technically and everything through the whole process. So just a thank you to our funder. We had multiple partners. That's why the project's particularly complex. We had 5 universities across Canada participating. We had 9 community organizations. I won't read through them all, I'll just list them here. Our largest project, of course, happened in Toronto between Child Development Institute, the University of Toronto, and Children's Aid Society, Child Welfare Institute. That's where the largest part of the research took place, which you'll see and that's what we're going to be focusing on today. There's lots of little offshoots, as you'll hear, but we are just going to focus on what's really been impacted around Child Development Institute. So what was the Safe and Understood project? And we really came up with this name because we're really thinking about how young children are disproportionately exposed to violence, and I'll show a slide about that, and how little was out there in terms of practice with these really vulnerable children and families. And of course, they're more likely to be investigated by child protection. So our target population, it was a 5-year multi-province project. As you can see, families with young children who've been exposed to domestic violence or intimate partner violence. You'll hear me talk about both. That was substantiated by child protection. So we were really looking at a very specific group of families. Our main objectives were to improve outcomes for these young children who are under the age of 4 and are particularly at risk because of domestic violence exposure. We wanted to prevent the reoccurrence. So we wanted to stop violence from happening in these families. We wanted to reduce impairment, which is to stop any to address whatever impact from violence that children have already been exposed to. And we really wanted to look at expanding the reach of programs such as Mothers in Mind and Caring Dads, and looking at how to implement these programs within different contexts. For example, we implemented in a Francophone community in Quebec, and we also implemented in Indigenous contexts. So as I promised, I wanted to talk quickly about why we even thought about this project. First of all, we know that about 500,000 children are exposed to domestic violence in their homes every year in Canada, and that this exposure to violence in the home is one of the most frequently substantiated. It's not just one, it is the most frequently substantiated form of child maltreatment right now, and the majority of those are for children under the age of 3. Young children hold the greatest risk in terms of long-term adversity and outcomes because of a number of issues, not the least of which has to do with the fact that these children are disproportionately exposed because of their young age. They're more likely to be held in their mother's arms at the time of an assault. They're also developmentally more vulnerable and require all aspects of their well-being to be modulated by the caregiver. So lots of complexity and combining of issues, which makes them so vulnerable. We know that men who abuse their partners also abuse their children directly, and that children who are exposed to this kind of violence show similar outcomes to kids who are themselves directly physically abused. We know there is a lack of intervention services available to meet the needs of these very young children. I'm just going to ask again for people who've just joined us to mute your microphones. Thank you. This is our conceptual model that was developed by Harriet McMillan at McMaster and others. And again, just to look at, can we target these families to prevent the recurrence of harm and to prevent impairment and improve long-term outcomes? This is our project timeline. It's a bit confusing, but we'll try to make it as clear as possible. 5 years, so CDI was awarded the public health money. We then partnered with the University of Toronto and Western now, because Katreena is also now at the Center for research on preventing violence against women and children at Western. So we've got this dual partnership now. We did a national scan to start immediately. We went across Canada and talked to organizations across Canada by province and to find out what kinds of services were available for children under the age of 4. We then partnered with Children's Aid Society of Toronto, Changing Ways, all the organizations that we listed, and we started to provide Mothers in Mind and Caring Dads facilitator training to all of those organizations so that they could start to implement these programs. And specifically at Children's Aid Society of Toronto, we started putting Mothers in Mind and Caring Dads groups into their programming, right embedded, offered right at their services, right at the point of entry for families. And now we're in the process of our knowledge translation. We've been doing that for a couple of years. Just briefly, this national scan, again, was to look across Canada at what is being offered. We specifically asked about domestic violence exposure, mothers' experience of trauma. We wanted to know about dyadic interventions because Mothers in Mind is specialized in that piece. And we heard about a lot of home visiting, postnatal, and parenting support groups that were not focused on domestic violence and trauma specifically. So those were taken out of our search. So what did we find? We clearly have gaps in our current services around parenting. There were provincial, we looked at part of the scan, so I should have said this, provincial and territorial action plans. We read them all. Yes, it's not as fun as it sounds. That they rarely include a focus on children, let alone young children. Most commonly available are general mental health services that provide therapeutic intervention, but very few indicate any capacity to reach the needs of children under the age of 4. The largest initiative we have across Canada are our child advocacy centers, as some of you must know about these child and youth advocacy centers, but very few, again, have any capacity to serve children under 4, and they tend to specialize in direct child sexual and physical abuse. The violence against women sector provides education and support for mothers. Many have programs for mothers and children over 4. Again, very few children are being served under the age of 4. At the time of this national scan, and I can say even now, Mothers in Mind is one of the very few programs that actually does this work. So for anyone, I'm just going to very briefly talk about Mothers in Mind. This was developed at Child Development Institute, and it's a trauma-informed mother-child play group. It is fully interactive. Moms and children are together throughout their time with us. It's originally a 10-session closed group. When we were offering service to child protection mothers, we did expand that to 12 sessions to increase the capacity for mothers to participate and benefit from it. There are 2 to 3 facilitators for basically every mom would have, every 2 mothers has a facilitator available to them and their children because of how intensive the work is, the dyadic work together. It's very relationship focused. It looks at parenting within the context of trauma. Rather than addressing trauma itself, we talk about parenting in the context of trauma. We use play, songs, and stories to support this work, which again makes the program more like a play group than this feeling that you are in a therapeutic intervention. Our goals are quite simple. We want to reduce a mother's stress related to parenting and her experiences of violence and abuse. We want to strengthen her feelings of self-efficacy, that she has the ability to impact her child. We want to provide opportunity for women to access trauma-informed parenting support in a safe and supportive environment. And we want to support women in connecting with other mothers with similar experiences to reduce that feeling of isolation, as well as shame and self-blame around an issue that is actually quite prolific across Canada. And we want to support the positive development of the mother-child relationship. Thank you to those of you who are joining us now. I would just ask that as you join to mute your microphones. Thank you. Mothers in Mind runs under trauma-informed practice principles in that we recognize the impact of trauma and focus on minimizing re-traumatization. We explore factors that impact parenting, and we consider cultural, historical, and gender issues in terms of this work. We focus on healing through healthy relationships, peer support, and maximizing women's voice and choice in the process. I will now put this over to my colleague, Dr. Katreena Scott, who is the founder and developer of Caring Dads, to explain this program. And again, I'll ask anyone who's just joined us if you could just mute your microphone. Thanks.
Good morning, everyone. As Angelique said, it's my pleasure as well to be here and to be able to talk a little bit about the work that we've been doing over the last 5 years. We are not focusing as much on Caring Dads today, but I do want to give you a sense of the program and talk a little bit about why we were so excited to be able to look at them together. So Caring Dads, I don't think I have, oh, I do. No, could you? Yeah, so Caring Dads is a program for fathers, and it's a program for fathers who have behaved in ways that cause harm to their children and families. So fathers who have abused their children, who have exposed their children to domestic violence, and who have engaged in neglectful and harmful emotionally abusive behavior. The program itself does look a little bit more like a therapy program. Men come together for group sessions. They meet for 17 weeks. There are about 10 to 15 fathers in the group. And there are individual sessions peppered through and on a couple of different times in the group so that men and the facilitators and their referrers meet to clarify aims and then to set really concrete goals and then to monitor progress. Also associated with Caring Dads is a mother contact. And in this project, what we were able to do in many cases is ensure that that mother contact was done by a woman's advocate. So this is mother contact aside from any child protection involvement, but somebody with specialized knowledge of domestic violence who can reach out to moms and ask her about her safety and ask her about the support that she needs and get feedback from her about what she needs in her relationship and what she needs in terms of her support. And that all feeds into what I said about coordinated case management. So the idea of Caring Dads is that we're not going to work with dads sort of individually without reference to what's happening in the family, because in Caring Dads, our main aim is to end abuse, fathers' abuse of kids. And that also means ending fathers' exposure of their children to domestic violence. And to do that, we need to be working together with people who are working with kids' moms, with people who are working with children, so that we can set adequate goals and monitor men's progress. So the program has those three components. And then when we meet in group with men, we have, the next slide's great, 4 sort of specific goals of the program. So the first goal, we take them through on this 17 weeks is really about engaging men and developing sufficient trust and motivation to have them take a look at their fathering. So as many of you will know from talking to moms or even from their experience in talking to men, men are generally not eagerly seeking intervention, and they often have a very distorted view of where the problem lies. So there's a lot of blaming of moms for the problem, there's a lot of blaming the system for the problems, and there's inadequate recognition of his role and his responsibility for the problems that are happening, for the impact that he's had on his children and on his partner and on his family, and for the fact that his current situation is as a result of the trauma he's caused for his family. So the first goal is really to meet men where they're at and bring them along to understand and recognize some of the reasons why they need to take a look at what they're doing and think about change. The second goal of the program is really to help men shift their awareness and put their child at the center of their thinking. So parenting and relationships with children and relationships with your family, we work to have men think about that as being what does my child need from me? What is my child experiencing from me? How is it that I need to change to do a better job at meeting my child's needs? And all through that is recognizing that children's needs and the safety and well-being of mothers are intricately connected. So we talk a lot in Caring Dads about you can't be a good dad and an abusive partner. The third goal then, after men have come along to this point, we then set very concrete behavior change goals with men. And we do that with men, but that's when we also need the feedback from our mother contact people and from our referrers. What's it going to take to change, to reduce the risk to this child? And so we work with men on those very specific goals. And then in the end, we're thinking about, okay, what's next? What do we need? What's change still needs to happen? And how do we proceed from here? And the reason, thanks, Angelique. So the next slide, this is the reason, this slide, which anybody who's seen me present before will have seen me show. This is the reason why over coffee, Angelique and I said, we really need to do this work together. Because one of the things that happens in our system is as we focus on and think about, we need these kids to be healthy, we need these kids to be safe, that we then turn to moms often and say, okay, mom, what are you doing to make sure the kids are safe? And when the harm to children is being caused by fathers, that's not fair. It's not fair, it's not appropriate, it's not right. What we need to be able to do is we need to be able to provide moms with intervention for the impact of domestic violence. We need to be able to support her and empower her in keeping herself and her children safe. And we need to be able to provide her with the support she needs. And that means not making her responsible for his behavior. We need to make him responsible for his behavior. And so by pairing these two programs, one that's saying, Dad, this is the harm you've caused. You need to stop causing harm, and keeping the focus of that work with him as the person who's causing harm, it frees us up, in fact, to do better work with moms. And so that's why these two programs conceptually pair well together. I'd just say one more thing about Caring Dads. So Jess says, with mothers in mind, we had the investment from public health allowed us to do a number of things that we hadn't been able to do before. Part of it is research on this pairing of programs that we hadn't done before that we're going to talk a little bit more about. We were also able to offer the program in French and French for speaking environments. And we were also able to work with an imam and a community organization and make an adaptation of Caring Dads for Arabic-speaking fathers, and to offer that program as well. And I'm passing it back.
Okay, so thanks, Katreena. So Katreena's just sort of given us a nice little intro into the implementation process. So I think we just talked a bit about what we needed to begin to implement these programs in multiple contexts. We wanted to be able to provide some level of quality control. We had lots of interested organizations. In both of these programs, we have program licensing. We developed sub-grant agreements detailing the organization's annual funding budget and deliverables as part of the project. We had facilitator training for all staff who were interested. We hired internal Mothers in Mind and Caring Dads coordinators within the organizations where we were doing the most work. We provided all the program materials, the children's books, tokens for group participants to use the TTC or gas money in rural communities, for example. And we provided compensation for participation in program evaluation components. We translated and provided French adapted program materials and program materials manuals, and we continuously collaborated with program experts in our program consultations. So just to give
can I just add one of the reasons why that was so important, as Angelique was talking at the beginning, there's not a lot of people doing this work across Canada. As a result, then there's not a lot of people who have the expertise to do the work and the experience and the practice knowledge. And that part of the program of spreading that practice knowledge, I think, is really important.
Thank you. That's a good point. So this is our facilitator training across these 3 years. We offered a number of sessions and total training, 340 facilitators were trained in Mothers in Mind, and 210 individuals were trained to provide caring dads. It's a huge build in capacity. We also offered these Mothers in Mind and Caring Dads groups. You can see the numbers across the provinces, but again, in total, in a 3-year time frame, we offered 25 Mothers in Mind programs and 22 Caring Dads programs. As a result, we reached 120 women, 178 dads, and 760 young children were impacted by this project. We had a number of research study designs. I think this is over to you, Katreena. Did I talk too much?
No, sure. I'm happy to talk about this. So there was a number of bits of research that was built into the program. So we have some work on looking at program evaluation and program efficacy. We have some work, which is a cluster randomized control trial, particularly in the work done in Toronto and with the Children's Aid Society of Toronto. And we also wanted to look at the implementation process and what does it take, what are things that facilitate and are challenging to agencies that are adopting these programs newly for the first time. So I think we're going to start with talking about the outcome evaluation of MIM. And in particular, we're going to talk about the MIM programs that were embedded within services at the Children's Aid Society of Toronto. And we're going to do that not because all of the services offered as part of this project were embedded with child protection, but because this was a novel aspect of the project. And we wanted to really look at whether or not the outcomes achieved when we were able to work closely together with child protection matched or were similar to the outcomes achieved in MIM programs in general.
And the other reason for this is that historically, the first Mothers in Mind program was funded by the Ministry of Children and Youth Services, and it was designed to improve this, to reach a service gap in women and children who are coming to the attention of Child Protection Society for exposure to domestic violence. And of course, we have Here to Help at CDI, but these were for children under the age of 4, as you saw in the stats. They had huge numbers of families where there were no resources for them to send them to, and CDI was specifically funded to address that need. But what we also found was it was really hard to make that connection between your child protection worker telling you to go to CDI and you actually getting to CDI. And in many ways, we saw women that came to us through other avenues. This was a way of being more directive in our practice. So we looked at what was going on there. I'm going to just, really you need this on a giant poster board on your wall to be able to read any of this, but it was just to sort of illustrate that we had a program logic model and it's directly linked to what the program outcomes are and the tools that we use to measure those outcomes. You'll see we use the trauma-informed practice scale, a self-compassion scale, a social support scale, an anxiety depression scale, raising a baby, which is a child development scale, knowledge of child development scale. We use the TOPSY, which is a self-efficacy tool, and the PCODIS, again, all around looking at what's happening. Again, I'm just going to ask for muting, if that's possible, for anyone who's just joined us. So interestingly, we still got this is a small N, but it's a high N for the kind of moms that we were asking to be involved. These are all moms being investigated by Child Protection. So asking women to fill out forms to assess how well they're doing in parenting is a bit anxiety provoking, to say the least. So getting this number of women to not only agree to this kind of scrutiny when they were so worried about being investigated, but also given all of the things that are going on with them, we were quite pleased to have 65 pre and post at the end of the day. So we have statistical significance in the things that we were most interested in having, which is the increase in self-efficacy. So at the end of 10 weeks, 12 weeks, depending on the program they were in, mothers believed that they were more capable and confident and understanding and affectionate towards their children. They felt like they had an impact on their child's well-being. They increased their parenting knowledge. So we saw them reporting more knowledge of infant and toddler social emotional skills while attending MIM, which of course leads to more developmentally appropriate expectations of their children. You'll see some qualitative data connected to that that's quite powerful. Interestingly, we saw a decrease in parenting depression and anxiety. This was not something we thought the program could do. We just wanted to see whether or not levels of depression and anxiety impacted their ability to benefit from the program. But in fact, mothers just attending the program reported feeling less anxious and depressed. And there is some emerging literature out there that says that coming to a parenting program can be very helpful to women in this regard. We offered trauma-informed practice. Again, mothers filled out this scale and it indicated they were satisfied with the program and reported that facilitators were practicing in a trauma-informed way. These were all statistically significant. We have trends approaching significance, and if we had higher data, we'd be able to talk about this more fully. Perceived parental impact is increasing, trauma symptoms are decreasing, parental warmth and involvement are increasing, all positive trends. Interestingly, we saw no change in self-compassion, despite qualitative data that illustrates the group components of this are very important to mothers. They take it away with them. We suspect that it has something to do with the measure, or perhaps the concept itself is a bit foreign for some. We saw no change in level of hostile reactive behavior, which is technically good because that means that the levels were already low, so they did not decrease. We thought might be seeing more concerning behaviors, especially with a child protection population, but this combines well with the literature that we know that indicates that women who've experienced abuse are no less likely or no more likely to be harmful to their children as opposed to managing parenting within the context of trauma. We had some interesting motivation to attend mothers in mind because, again, they're child protection workers being the first point of contact. Many women said the description of the program fit with them and made them realize they weren't alone. They believed it was something they needed to do in order to get their children back. We did have women whose children were in care who went through the program, and they indicated that it was a chance to spend time and connect with their children and obtain needed resources such as free books and food. The reasons they gave for completing the program were that they were actually learning about themselves and their children, particularly around child development. They talked about managing stress and developing self-care strategies. They felt like facilitators cared about them. And you'll hear interesting data around how going through the program made some mothers feel like their child welfare worker cared more about them as well. The actual enjoyment of the program, they talked about children wanting to go, moms getting the support and getting their own needs met. And here's a quote from a mom. She said, "Mothers, kids, and people who care are around her for her to learn things. And, be a little bit social." She really likes going there, talking about her young toddler. What did moms take away from this program? Overwhelmingly, women talked about gaining self-confidence in their parenting and feeling a stronger bond with their children. You'll see a couple of quotes here from our qualitative data with a mom talking about really getting to know her daughter more, getting to spend time with her, learning about her cues. Another mom talking about gaining her self-confidence and connecting with her child. But they also learned about what to appropriately expect from their children. In some cases, this altered their behavior. So we saw new rituals like bedtime and reading baby books that became really positive experiences for both mother and child. So here's a mom saying, "I always used to hate him for the things he did, but in this program, I came to know that children are like that. They have to be treated and respected in a very nice way because they are children, and sometimes we really forget the fact that they are children when we're in our own stress. Another mom said she didn't realize there were baby books. You might realize poverty is a real thing, and a lot of people don't have access to this kind of literature. She was talking about her child. She was talking up a storm compared to a lot of kids that were older than her because I was constantly reading to her and talking to her. The supports they received from both facilitators and mothers were really powerful, from each other, for example. They reported the most helpful aspects of the program were this respectful and empathetic environment. So again, when it comes to Mothers in Mind, the facilitators are key to delivering the program. The manual itself cannot be just delivered by anyone. You have to be very therapeutically inclined. The engagement level, the amount of connection with moms is actually what makes change occur. Developing new skills with parenting and bonding with their child, peer support. 73% of the mothers were extremely satisfied with their Mothers in Mind experience. I'm going to let Katreena talk about our cluster randomized control trial.
Right. So I want to let you know that the other part, so this is, we just were talking about program outcome work. And the other part is we're really trying to look at can we improve the outcomes for child protection involved moms and kids when we embed these kinds of services and work together. Can you flip to the next slide? So I just want to talk a little bit about what it meant to even run this research and what it meant to do this embedded service provision. Because as Angelique said, CDI had been accepting referrals from child protection even prior to this. But then what does it take to actually think about how do you work really together within a child protection context and then to add research on top of that? So we had to spend some time developing some shared goals and some shared understanding. We created a system for collaboration and a system that helped identify for research and also for practice those moms who might be a really good fit for MIM. So most of the time, MIM runs on either moms voluntarily deciding they want to come to the program, or perhaps a child protection worker knowing about the program and referring her to it. But we also wanted to say, okay, well, let's look at all the moms who are involved with child protection services, where they do have young kids, that the concern was child exposure to domestic violence, and that there are concerns about moms parenting. Let's look at that whole sample of moms and see what it might take to provide service that is helpful for those moms. So we actually had work done right in the agency. We embedded CDI people in the agency. We had a specific person within child protection to do some of the communication with the workers. We provided the groups at the child protection branches, and there's still work ongoing at the moment that we'll talk a little bit about. So we had then teams were assigned to 4 different conditions. So in order to do research as rigorously as possible, what we wanted to do is be able to compare moms who were in the program and who were not in the program. But we didn't want to be in a situation that we were randomly assigning moms to maybe get intervention or not. So what we did instead is we targeted our training. So because we had limited training resources and limited group resources, what we did is we took particular teams, particular child protection teams, and we worked with them around what do we need to do to help you develop your understanding of what moms and kids need? How do we make sure that you have access to service? How do we make sure that we're reminding you that these moms might be a good referrer? How do we make sure we get those moms into the program? And so we targeted particular teams to get sort of preferential training and access to these programs. Okay. So let's just talk about that professional training for a minute. We did 3 sessions of professional training to those teams that we had targeted to be, in this case, I'm going to talk about MIM teams. So we've got these teams that are going to do, to get more information about kids' needs, young kids' needs in the context of child exposure to domestic violence. So in the first session of training, then we went into those teams where they were already doing their team meetings. And we talked about identifying patterns and indicators of risk for kids in the context of child exposure to domestic violence, and really about strategies that might be useful to engage moms in the idea that she may benefit from a parenting intervention. In the second session, we did a clearer description of the program. So again, caring dads or mothers in mind. And we helped child protection workers map the goals of the programs to signs of safety, which is a framework what they use to think about why are parents and why are files remaining open and what needs to change for the child to be an indicator of safety that will allow the file to close. And then in the third session, we talked about supporting and maintaining changes in clients that attended the programs. In terms of how much training we did, so we talked about training in MIM facilitation or in caring dads facilitation, but in here we're talking about training child protection workers to think about child exposure to domestic violence and the needs of mothers and fathers. And so we trained 15 child protection teams, which translates to 120 workers receiving this training. And also we put this online and made really toolkits for workers. So those workers also received sort of ongoing access to their respective programs outline, online portal, which had handouts for each of those things and little booklets around recognizing risks, thinking about child needs, thinking about what the program does, recommendations and suggestions for making referrals and following up with families. In terms of results, the child protection workers were highly satisfied with the MIM trainings that were provided and with the resources that were provided. They liked it. And what we did is we actually first asked them about their confidence in making referrals, but we also gave them a case and said, okay, here's a situation that you may encounter. And we asked them to identify risks and set goals for moms and ask them, how would you know that the file could be closed? And for the MIM training in particular, those workers who went through that training were better at conceptualizing those questions than workers who didn't. So as compared to workers who were randomly assigned not to, they were better. That being said, the other thing we wanted to follow up with is, were we able then, or were those moms able to get to group? And here, I would say that we still have some work to do. So over the course of this project, there were 60 families, 60 moms and kids who we identified kind of at the front door as being a potentially good fit for a referral to mom. And they were a potentially good fit because, as I said, they had young kids, they had been exposed to domestic violence, they continued to have contact with moms and dads, and the intake worker at Child Protection said, well, you know what, yes, I think that there's some work that their goals were for mom to get some more knowledge, to be able to parent better, to have a better understanding of how her trauma impacted her parenting and what the needs are for their kids. So then we asked, did they actually get referred to the program and did they actually get to the program? So what we see is that of those 60 moms, 24 were referred to the program. And then of the 24, there was pretty good level of engagement. So 13 of them ended up being completing the MIM program. There were some that didn't engage. In some cases, for 2 of them, it was because they'd already been to CDI or they were going to go to CDI. And then for some others, there was some concerns about engagement or about being able to attend groups during the day and meeting groups really at different times. So for me, I think that this talk speaks to both the success and the possibilities of embedding service and getting to moms that we wouldn't necessarily get to otherwise. And I think the ongoing challenges of working with a complex and multi-need population. Angelique, do you have more to kind of say about this particular part?
No, I think you covered everything, actually. It made me again think about how fortunate we were to get 65 pre and post when you saw how much work went into the eligible condition. We still got moms through other ways.
Yeah. Okay, so we also did, so this is, I talked a little bit about what this tells us in terms of just the sheer numbers. But we also are exploring this kind of on an ongoing basis by reviewing child protection files and taking a really close look at what happens when we try to collaborate between child protection services and child and family mental health services. And so we're just going to talk about that a little bit.
So I think I take over here because this is our qualitative pieces. When we took a closer look at what was happening for women who were attending Mothers in Mind at CAST, we were very worried about their experiences of going to a therapeutic program in an organization that was investigating them at the same time. So we specifically asked them questions about that, and we definitely got themes around worries about surveillance, that people are watching and writing things down. But interestingly, this was managed through a transparent process. So we had joint meetings between child protection and group staff, and there was an emphasis on consent forms. And once moms realized that we weren't talking about them behind their back, this kind of anxiety went away quite quickly. And then it evolved to this feeling that workers were actually on their side, were on the mother's side, and that, we had a mom at the end of the program who said, could I go through the program again? Because in the beginning, I thought it was a trick by my worker to take my child away. But now I realize you were all just trying to help me. And I think I could have participated better and gotten more out of the program. Can I come back? Seen as again, it was seen as a support and additional visits for mothers who did not have custody. They were talking about being able to actually see their kids at the program, but they also talked about having increased access to their child protection worker, saying it was actually convenient because I would get to see my worker after if she was there and if I needed her. And I had a couple of issues a couple of times, so I was able to get to my worker and talk to her right away. Interestingly, the Caring Dads men said this a lot too, which sort of indicates that there might be more avenues for child protection workers to have relationships. It seems people aren't always trying to stay away from them. And this brings us right to the relationship with the worker. The relationship with the children's aid worker actually often determined whether the mom was going to attend the program or not, or if they benefited. So we had one mom who talked about being referred to the program by her first worker. And she said, I went only once. I didn't understand why I was there. And then she was transferred to another worker who took the time to talk about the benefits of the program, facilitated those introductions to the Mothers in Mind CDI staff who are working there. And she ended up completing the program and feeling really connected to her new worker as a result. In some cases, as I've mentioned in a previous slide, mothers access their workers more often and as a result had a better relationship with them. So again, we actually, not only was the program really therapeutic, but we improved relationship with their workers. So being a mother, sorry, Katreena, can you mute yourself? I think, yeah.
It's not me, but
yeah. Oh. Someone is
Wendy, this is Len. Can you mute your mic? Thank you.
Thanks. It's just the typing.
I'm so sorry. I thought I was muted. I'm so sorry.
It happens to us all. Being a mother, I was scared in the beginning. Like I heard a lot of things, but when I met her and the way she represented, I thought like, it's okay. She's here to help me. Again, we saw improved parent-child relationships. Women talked about watching the development of their children. Some children actually learned to crawl, walk, and talk while going to the program. And they had those shared moments of watching that development, but they also watched each other improve. There was a mom who talked about watching another mom smile for the first. She said, I'd never seen her smile before. And somewhere, at the end of the program, she was smiling. They also talked about beginning to see their children in a new and more positive light. And this, I think, is, if I could highlight any part of this presentation, it would be this piece here. this mom talking about, I've learned a good part about my child being in this program. They have brought, meaning CDI's Mothers in Mind facilitators, have brought a light into the good part of him. If I say he's troubling me, the same trouble word, they will change into like active. No, he's super active. If I say he's bugging me, they say, no, it's not bugging. They need you. This is, and she said, so they are redirecting my thoughts. That's the most important thing of this Mothers in Mind program. This is in an interview long after the program has stopped. She has kept this reframe about what she thought her child was doing and what she suddenly realized her child was doing, and how that entirely changed her relationship to her child. We know this from the literature, but to see this happen in such a small amount of time, this is absolutely game-changing for this mom-child and for the relationship and for this child's trajectory. Right now, we've done a preliminary Children's Aid file review. So what we were looking at afterwards is who got the program and what does it look like. Again, what we have found is the relationship with the worker is key. We know that not everyone needs to go to group or to programs, or that not everyone will. There are multiple avenues towards change. But if they aren't engaged in a program, then additional work needs to be done. And that's not actually the case. There's actually less activity if they're not getting the referrals. Some parents are saying no, but what we've found that in most cases, they aren't actually getting a chance to say no. They're not even being offered these services. There's a lack of engagement, as illustrated by the families who attended. The workers made all the difference, and I've talked about this mom already. So we continue. We will go for another, we're still pulling files at the 2-year follow-up point to find out why were only some moms referred to mom. So we have qualitative data on that. To MIM, sorry, not mom, outcomes between mothers who went to Mothers in Mind versus mothers who didn't. And are there differences in conceptualization outcome by worker demographics? So we want to know, is it because they had a certain supervisor, or did they have violence against women training, or is there something that is specific to the worker that's making them different as well? Finally, we implemented our program in a number of different contexts. So there were a number of challenges and successes with this. The different contexts I've already spoken about: rural, Indigenous, French community. We had our training resources. We now have a full website. We have ongoing coaching and consultation offered through CDI. We have institutional resources at the level of everywhere that it's being run. Institutional resources are what helps. So can they get access to that coaching? Do they have all the materials? Do they have staff? Staffing is the biggest issue, which makes perfect sense because we've just found over and over again that the relationship is what matters and the skill at delivering the program is what matters. So the longer you have staff in that position, the better your program is going to be. So when we funded a position that was there all the time, for example, at CAST, that uptake was better. The environments of implementation were very interesting. In our urban environment, we had so much diversity. We had interpreters. We had to have multiple locations. You can imagine Toronto is a huge city. Women couldn't get to the program unless we offered it in multiple locations. Rural, the location became an issue. Recruitment, hard to get that many moms who have a child under the age of 4. And then, of course, you have relationships. When it's a rural, close-knit community, we found this in our Indigenous programming as well. Moms were concerned. Sometimes they didn't want to go to a program because they thought people would know them, or they actually knew the facilitators. In other times, they would say, oh, I want to bring my sister and my best friend. And, relationships always change the dynamics in a group. Language specific, in our French community partner sites, we face challenges in the translation of material, but really because of the children's books and how important they are, very few of the therapeutic children's books that we use are available in other languages. We also saw differences between whether the program is offered at a women's shelter versus a child protection agency, which would seem to make some sense, but it also has to do with access. And for example, in a women's shelter, how long are they going to be there? How often is the changeover happening? So we might not be able to offer a fully therapeutic program there, but more of a drop-in psychoeducational offering. So in conclusion, I just want to be mindful of the time. We're doing well. Collaboration and partnership were key to success of Safe and Understood. We had a lot of communication. We have met regularly every week for 5 years. We've had team meetings at CAST with all of our partners. There's constant contact. There's lots of opportunities for feedback. I think I was just speaking with Lisa Sura the other day, and she's talking about all the ways in which they were able to shift and change practice with child protection workers over time, how that changed the work of CDI. We definitely made some changes to the program during our the work with our Indigenous partner. We learned some things and changed it for everyone, for example. We had champions within organizations. That's how the program keeps running. Again, that regular staffing, someone who is the Mothers in Mind or Caring Dads champion. The resourcing, funding for staffing and materials, at the end of the day, it often comes down to whether or not we have the resources to run an effective program. And this brings us back to our thank you to our Public Health Agency of Canada, who the relationship with the funder really helped us. I like to tell people about how when COVID happened and everything was shut down, we had to make some really innovative changes to service delivery and trying to get our last little bits done, and having the opportunity to be able to go to your funder and saying, here's what we'd like to try, and can we? And that was fantastic. So those are our successes. What we learned is with working with moms and dads around parenting in the context of child protection for DV is difficult. We knew that was going to happen. There's a level of complexity and challenge in how families are presented. We learned how to most effectively train and assess clinical capacity to do this work. We see continued issues. The conceptualization of DV in practice is still problematic. The idea that mom's behaviors are protective while father's behaviors are causing risk is what we're really trying to shift continually. We're making headway, but we want to make more. And we want to continue this practice of a model there's still a practice of a model that equates separation with safety, and we know that's not true. Mothers in Mind works, even in different contexts. That's our bottom line finding. What we'd like to do is continue our 2-year file review. We're going to publish the results. I'm going to show you a couple of slides in a minute, show you what we've done. This is ongoing in Australia as another project and is being written up. In terms of Mothers in Mind, how do we make Mothers in Mind a part of an integrated plan of support for families in child protection practice, at the level of child protection practice? How do we implement a sustainable model in child protection organizations? So thinking about child protection agencies as partners in funding the program on an ongoing basis as well. What is next for Mothers in Mind now that Safe and Understood is finished? Obviously, CDI should continue to be the leader in doing this work because there's an incredible need, and there's not a heck of a lot out there. As I wrap up here, our recommendations are that we need programs like Mothers in Mind, and we need that implementation support. We value working directly with child protection to reach mothers who might not otherwise become part of the program. I think there's a lot of moms who are still out there that could benefit that aren't quite getting to us. Ongoing work needed to work collaboratively, effectively across child mental health and child protection. There's learning on both sides that's continuous right now. And I think we've learned the value of continuing to invest in research, because as we learn things, we can adapt and change and do better at them. Just a quick overview this is about a year and a half, maybe. We've already done trainings that have reached 609 people. We'll be doing much more of this, and many of the presentations that we were going to do in our final year were, of course, canceled because of COVID. We have 7 publications out already and another 11 that are under review. So lots coming out in the coming years, and we have lots under in preparation, as we would say, right, Katreena? Lots that we're working on. So I'm going to wrap up that. We are perfectly on time. It is. We have some time for questions or thoughts. I can take them in the chat, or you can just unmute yourself and ask the question. So for those of you who are new, you can just go, there's a chat button. I hear someone taking their mic off.
Hi, Angelique and Katreena. It's Shannon here. Can you hear me okay?
Hi, Shannon. Thanks.
Leaning into my laptop. So for people who don't know, Shannon Hurley from Public Health Agency of Canada. First of all, I just want to let you know there's a few new people who have joined the Family and Gender-Based Violence Prevention team at PHAC, and they're on this, listening to this presentation. So I'm so happy. What a great way to get an introduction to the kind of work we've funded, and such a really leading example of, you know, I think the first time I talked to you both on the phone, I said, this is a model. This is the kind of thing we want to support. This is exactly what we're looking for. And so thank you for presenting. I know this is high level, but it's a lot and it's really helpful to us. Yeah, so what's my question to you? How can we in the government, we're always struggling with our federal role, and you know, our role is not to deliver services, and it's certainly not to direct provinces and territories in this area, but it is to support the development of knowledge and sharing that knowledge so that effective approaches can be taken up more broadly. So now that we're at this point, there's obviously more to do and more research to be done, but you've got some really great findings so far. How can we in the government help? We absolutely agree and are on board with this idea that child welfare needs to move from the idea of reporting and apprehension to supporting families. And this is such a great example of how to do that. What more can we do to help with knowledge mobilization, help you use what you've learned and the publications that are underway or that are already done to help get attention to those or help get uptake?
I'm going to start by talking about the fact that we don't have the mention of this kind of service or intervention in the provincial and territorial domestic violence action plan. So that's a governmental piece. So maybe a national action plan that looks at that, and also looking at ways that we can both support and offer change processes up to child protection work. Katreena, I think you had a couple of ideas too when we were talking.
Yeah, I thank you, Shannon. I appreciate that question, and it's a big and an important question. One of the things that I keep coming back to in thinking about this particular presentation and this particular work is really all the stuff that we've learned, and we've tried to kind of touch on some of it here, but you know, we like to stay in our worlds. We like to stay in our kind of child mental health world, or, you know, I can talk about caring dads in men's intervention world, or in our child protection world. And the families aren't in those worlds. The families are in the worlds that have to deal with both, and they are in the worlds where they can benefit from both. And I think that just as we teach and we talk a lot to parents about being child-centered, right, about, you know, what is it that your kids need? I like to think about what is it that those families needs? What do we need to do when we're working together? And I think that there's the ongoing communication of the need to kind of work across contexts is really important. And I think that kind of, it makes me think as well about making sure that we can conceptualize that well, because that's not as easy a research outcome as this level of this or this level of this, right? It's more the learning that has kind of happened all the way along through the conversations with people, through the push and pull of a child mental health perspective versus a child protection perspective. When we're looking at conceptualization and thinking about, okay, so how do we spread that conceptualization, but then how do we understand the layer of child protection needs on top of that? So those, I think spreading that interagency, intercollaborative work is also really important as we do this work.
Well, and part of, Lynn, I'm going to have you up next, but I just wanted to say that, Shannon, part of the other thing you did as government and as a funder was you built in that collaborative knowledge mobilization piece through the knowledge hub. And there are ways in which, like at the research level, if we could figure out how to do the kind of thing we've been doing in those knowledge hubs at a community practice level, think of what we could be doing. So Lynn had a comment, so I'd like to open it up to her.
Hi, Shannon. I'm the CEO of the Child Development Institute, and I think your question's a really pertinent one. And although I understand that the federal government doesn't have a responsibility for direct service delivery, I think that this is a really good example of how support to programs in a network can really help in terms of ensuring program fidelity and being able to provide a level of technical assistance that helps small organizations that are trying to deliver an evidence-based program do so and in a way that achieves the outcomes, and by having that same kind of support at the network level around implementation and ongoing program delivery can also provide these kind of evaluation results that, again, has a value at a network level, because you can see those outcomes across all of the programs, not just the individual kind of program evaluation. And so I think that this is a good demonstration of the role that kind of system level support of a network of programs can provide, and ensure that those programs and those efforts that organizations are making to support the families in their community have the most impact, and that there's a real value to having that kind of network and expertise available to help support programs, that they're delivered effectively, and then to monitor and be able to report the outcomes.
Thank you, Lynn.
Yeah, that's great. Absolutely. And we're seeing a lot more of that kind of model, that it's not just a bunch of siloed individual investments, but it's connecting and trying to change across systems. And that really is in public health. We're not limited to a single lane, because determinants of health come from many sectors. So Katreena, I really appreciate your points about maybe a role that we can play in trying to bridge the sectors or to help you in that role. So thank you. And I know it's for us to figure out what we need to do, but glad to hear your thoughts, and I hope we'll stay in touch and keep strategizing.
Oh, we'll stay in touch, Shannon.
Yeah.
Any other questions or comments? So it looks like we don't have any. So I suppose we can wrap up. Sam, did you have any closing remarks or before we wrap up for the day?
Yeah. Oh, here, let me turn my video on. So I just want to thank you, Angelique and Katreena, for taking the time to share the results of this incredible study with us. And of course, this wouldn't have been possible without the support of PAC. And of course, the support of all of the individuals who were participating in delivering the program, and of course, the families who were courageous enough to engage in this study. I think this has shed a light on some much needed and very complex areas that contribute to multiple health outcomes, not just children's mental health, but the mental health of the parents. And it highlights some of the complexities of the system that need to be addressed. But there's a lot of hope, I think, in these interventions and that have been presented today that change is possible. And I think that my hope is that this conversation and the conversations to follow, as Angelique and Katreena, you continue to roll out the results of this study, it gets us all thinking about what role we can play in moving the needle, and particularly in these times of COVID, where for the next year or two, or who knows how long, families like this are going to be particularly challenged. we know that, and Lisa, who's on the call today, who's been, really innovating and trying to figure out adaptations, that these families don't tend to have access to technology, or they have additional barriers to accessing online services. And so we need to about the evolution of the program, continuing to think creatively about how we can all work together in helping these families who, are so capable of healing their relationships with the right supports in place and the right systems in place. And so I think I'm very grateful to you for the work that you've done, and I look forward to continuing the conversation.
Thanks, Sam. I just wanted to speak. There was a last minute little question that came up about, as a result of participating in Mothers in Mind, has Children's Aid Toronto seen that these cases have closed? We are monitoring the outcomes of, what reopenings and things like that. But I did want to speak to, from another project I was involved with earlier, is that, again, much like the leave ultimatum, when we think that success comes from separation or safety comes from separation, we've often measured success by case closure or lack of reopening. And what we found is that the more relationship that a woman has with her worker, if her partner comes back, because remember, we're really investigating women around an issue that she has no actual control over. So telling her to separate and to stay away doesn't mean that she can keep a partner from reattending our residence, having access with her partner, etc. So in this other study I was involved in, what we saw is reopening was actually a sign that the intervention was working, because women felt connected and safe enough to reach out to their worker and tell them that they were having trouble still. We should be expecting families like this to come back to the attention of the society, as long as we're not doing the work with the men who are causing the harm, which was Katreena's point in the first place.
Right. And that's exactly, I'll just kind of underline that. It's why I think we need to look carefully, and we are. That's why we're doing a 2-year review of outcomes for all of the families involved in the study, both MIM and caring dads involved families. But a target outcome for MIM is not reduced re-referral back to, it is for caring dads, right? Because if the concern is about his engagement in harm and his perpetration of abuse that results in child exposure to domestic violence, we need to stop that with him. And that's where that outcome belongs. We need to then think about the kinds of, I think, care that moms are able to get from their child protection workers. And I'll just go back to the point that Angelique made. We don't kind of think that everybody needs to necessarily be in intervention, right? But if we think about the families, we think about their involvement now, we've become involved in their families as a system, thinking about what do then they need from us? What kind of support do they need from us? And how are we actually providing that support? That's why we need to think about, if it is not being provided by MIM, that's fine, but where is it being provided? And the concerning kind of thing that we're seeing at the moment is that, it's the families who actually manage to get to one of these interventions that are getting any support. It's the support, we're not saying MIM is the only support, but that is one of the only supports they're actually getting. So it might mean even thinking about and working forward and thinking about helping to conceptualize multiple ways of doing that support. So the first part was, okay, let's think about MIM and let's think about conceptualization. But as we build that practice, and my hope is, there was so much learning that happened because there was these conversations between child mental health and child protection. And that learning didn't stay only within the MIM group, right? It then has to trickle into the practice. So how is that trickling in the practice? What can we see about that? And what can we look to build on in terms of that broader outcome?
Well said. Thank you, Katreena.
And I just wanted to let people know, as I said, this was kind of we wanted to touch on lots of different things, but there are other things that we're doing as part of this. So for example, we have done and published a study on how children who've been exposed to domestic violence, how they see emotions and what kind of biases they have there. So that's a more neurocognitive one. We have a paper that we're pulling together on parents their view of the workers and what they think is working well and what's not. We have work on this training and the conceptualization. And as we publish the results of this work, what we're doing is we're creating sort of short summaries that will be available, and they're kind of designed for everyone, so that if you guys keep your eyes open for safe and understood materials, they'll be posted in a number of different places, and you'll be able to kind of follow us for the next couple of years as we're making resources or putting findings out about the things that we're learning in this, that we continue to learn in this study.
And they will probably be on the Mothers in Mind website at CDI, as well as multiple other locations. Okay, I just want to say thank you again to everyone, and stay tuned. I hope we have an opportunity to come back and do this again.
Thank you both, Katreena and Angelique. It's Lori Marsden. I'm the clinical director at CDI. And you, Angelique, you know, I've been really looking forward to hearing these results. And again, thanks to you both. Congratulations for fascinating outcomes. And I think it just really reinforces, and it's been said, but how important it is to look at the whole family, as well as the importance of the partner between children's mental health and child protection. So it's, you know, this is, I think, really important groundwork for us to move forward. And I really would be wanting to continue to talk about how we do find a way to sustain this and grow it, actually. So thank you both.
And it's Lena here. I just want to echo what Lori said. You know, doing research is not easy. Getting kids and families involved is not easy, especially in your population, Katreena and Angelique, with regards to mothers involved in family violence. So the fact that you're able to get the sample size you did is excellent. And I also want to congratulate PHAC and Shannon. Shannon, you know, just your understanding and being able to be flexible, like Angelique had indicated, especially being able to alter in the middle of a pandemic and things like that is really, really, really great to see that government is working in partnership, true partnership with us, CDI, and others. So thank you. Congratulations. Excellent.
Thank you, Lena.
You're welcome.
And thank you, Lisa Sura, for being the CDI internal champion who has kept this all alive and well. It's so easy on the outside as the academics to be, okay, we need more participants, and we need this, and we need you to fill out this form, and we need you to do this. And can you get your staff to buy in on that? And can you go to 8 more meetings this month than you ever had before in your regular workday? So thanks to Lisa Sura for sticking it in there for us.
Thanks so much, and congratulations. It's been such an interesting ride over the last number of years, and we just appreciate all your support, and the findings are really exciting. We look forward to continuing to work with CAS and continue to run MIM. So really excited to the next few years. Thanks again.
It's our pleasure. Okay, so I don't know who's I guess we still have 19 participants, I guess, as people, I'm not sure who's, I think it's someone's hosting this, so we can just close the meeting out.
Bye, everybody. Have a great day.
Bye, everyone.
Thanks,
Thank you.
Bye.
Bye, everyone.
Bye.